But I'm coming to the management of fit patients, and I would say here in the room, if I look around, you look all great, and the majority of you must be very fit, actually, I would say. Congratulations. Maybe I'm misled, but that's my impression at least. So basically, next one, the physically fit patients. And the treatment that we consider standard is a combination of a chemotherapy. We think FC is a little better than FR with rituximab. And the study that has shown this, and this concept was pioneered at the MD Anderson by Michael Keating, who's here. And we did the confirmatory randomized phase 3 trial, shows that for the very first time, you change the overall survival. And I think this is important for you because it's inducing a different concept. In the past, before this trial was done, we could say, well, it doesn't really matter what you do in the first place. You can do one treatment, and then as soon as that doesn't work, you increase the toxicity, you increase the efficacy. You maybe start with an antibody, then you take FC, that does not work, then you can always do FCR or something else. Well, this trial would say something different, and that's why I think it's so important. If you do a very efficacious treatment in the first place, in the right patient, of course, the fit patient only, then survival is changing, which means you have to do the first thing right. That's the message. That's the important message of this trial. It is not basically a totally irrelevant factor how you start. It's, I think, a very important factor. We have some patients, and actually I know that some patients are even at the meeting here, that have been treated with FCR and for 10, 11, 12 years haven't seen any other treatment anymore. Which are those patients? Next one. Next one. So if we look closely into this trial on more than 800 patients and analyze what are the patients that benefit a lot from chemoimmunotherapy and have a long survival, you can easily distinguish, even if you are totally inexperienced in reading these Kaplan-Meier plots, that this is clearly separating at least 3 different groups. Let's start with the worst one, that's 17p, the black one. So in this group of patients, chemoimmunotherapy does not change anything. Basically a little bit, but it's not improving on this dismal prognosis. So in this population, we have to do something else, and we will come back to this. Then on the opposite, the pink, the green, the red curves contain 2 things. A mutation of immunoglobulin. All of them have this mutation, so they are mutated. This is an analysis on the mutated patients. The unmutated behave differently. Plus either a trisomy 12 or deletion 13q or a deletion 11q that was formerly considered to be of poor prognosis, but in this trial it's no longer of poor prognosis. If you have a combination of mutated IGVH plus one of the 3 genetic aberrations, and then they stick almost to the 100% line, so they are above 90%. They are surprisingly good, meaning that in this group of patients, FCR is probably achieving very long-lasting remissions and is a good thing to do in the fit patients. In the middle, the blue one, the light blue one, is all the patients that don't have any of the known aberrations, so they are actually falling out of any category as determined by FISH analysis. So this is actually, I would say, the state of the art. You look at the genetic aberrations, you choose this therapy, and you know that some patients will do very well, and they are characterized by these genetic factors shown by this trial. These data are unpublished, but they are going to come out fairly soon. The paper is now ready. Now the question was, can you mitigate the side effects of chemotherapy by simply replacing FC, which is a bit toxic, by bendamustine, the novel old Eastern German drug that somehow came into Northern America by companies and was reinvented, so to speak, but well, we know it, it was the only chemotherapy that the Eastern Germans invented because they had to do something about cancer, and so that was hanging around in this country, then came to Western Germany. We used it for 20 years. It was okay, and all of a sudden it was reinvented in the US, and it was great. And it's great. It's a good drug. It has less side effects, actually, than FC, but it's not doing wonder things, as you will see. So we tested whether FC can be replaced by bendamustine in a simple randomized comparison, also not published yet, but shown at the ASH meeting, and we will publish it this year. So simple comparison, next one. This is the characteristics, and to show you quickly, the trial was very well balanced, but these are younger patients, 60 years, so the fit population. Next one. And this is the stage distribution. This is also similar in both arms, with one exception, and that's the unmutated patients. We didn't know that this was so important at that time. Were a little unbalanced, so the BR arm was unfavored by this distribution. Next one. So here are the results. And to cut a long story short, BR is not as efficient as FCR. So it's inducing less complete remissions. The overall response rate, however, is identical. Next one. We now looked into the more stringent and more potent factors, and that's minimal residual disease. Minimal residual disease is determined by measuring single cells by either four-color flow cytometry or by doing a PCR, which we did in this case to determine whether you had residual cells in the blood or in the bone marrow. And you can see by every category, the numbers in the BR column are lower than in the FCR column. And all these differences are significant. So bone marrow at final restaging, does that mean? Or peripheral blood at final restaging? Or 12 or 18 months after final restaging. And let's just look at the last line. 18 months after final restaging, you have 18% of patients that are still in MRD negative remission with FCR and only 8% with BR. So BR is less potent. Next one. And that also translates into a shorter progression-free survival time. So the remissions achieved with bendamustine rituximab are shorter, and this is a highly significant difference. So BR is inferior. The overall survival, however, does not change yet. So in this trial, so far, no evidence for a changed outcome because there's always a subsequent treatment, maybe FCR, maybe novel agents, and so it did not change the survival. Next one. And there's a price for it. And that price is higher toxicity. So FCR causes, again, the same comparison, neutropenia, so white blood cells dropping, higher with FCR versus BR. Infections, if you look 4 lines down, higher, 39% versus 26%. So while you have a higher efficacy, you also have a higher price to pay, which is more infections, more neutropenias. Secondary tumors, so far no difference. So all the problem of secondary cancer after treatment, they behave similarly, we would say. And this means, for now, we have a situation where we counsel in Germany, at least, to use FCR for the patients that are, I think there's a next slide for illustrating this, for the one back here. Which is explaining what I'm going to say, that we counsel to use BR in the patients above 65. If you look in the infectious complications, which we wish to avoid, of course, in these patients, which is a very bad side effect to have, the differences are most prominent in the patients above 65. So we checked everything else. We used fitness scores and all these things. We didn't find too many differences, but the age was a good discriminator. So if somebody is above 65, we tend to use BR. If somebody is younger and fit, we tend to use FCR. That's what we currently do in our trials and also recommend in our practice. Because the infections in the patients above 65, last line again, are 47%, as you can see, as compared to 26% in the BR arm. So a clear difference, and that's why we think BR may keep a certain value for those patients. I think that's where we stand right now with chemoimmunotherapy.